hypertension. Now we have a lot of indications and contraindications that help us to choose antihypertensive agents. For instance, heart failure with reduced ejection fraction. ACE inhibitors are preferred, ARBs, beta blockers, diuretics, aldosterone antagonists, etc. We are not going to go over, but we have to know the specific medications which are preferred with each concomitant disease. Again, angioedema, don't use an ACE inhibitor. Bronchospastic disease, don't use beta blockers. Despite, in the past, we had some cardioselective beta blockers, etc., it doesn't work. When there is inflammation in the respiratory organs, cardioselective beta blockers become bronchoconstrictive also. So we have to be very careful unless we don't have choice. Okay, black and non-black, different preparation of medications. We mentioned that. And let's skip that. Okay. Now, one of the most important factors that will guide us to choose the best and the most effective medication for a patient is potassium metabolism. And we all know aldosterone antagonists were used for many years. They were almost forgotten. And then the huge studies about outcomes in heart disease, in heart failure, in myocardial fibrosis, ischemia, heart failure with or without reduced ejection fraction, and aldosterone rose again. Now, it is a very, very important medication. It is underused and should be used much more. Here we see in this slide is the progression to hypertension, only increase in blood pressure on the left, and development of hypertension on the right, according to quartiles of aldosterone levels. And we can see that the higher the aldosterone level, the higher the development of hypertension. So we can prevent development of hypertension. We all know the studies that Steve did with the candesartan. Maybe we need such a study with an aldosterone. It should be very, very interesting how we can prevent development of hypertension, probably even more convincing than the candesartan study. So spironolactone versus placebo, bisoprolol, and doxazosin was studied in the pathway study. Not a very big study, several hundreds of patients, and about less than 300 patients were divided to 4 groups: spironolactone, doxazosin, bisoprolol, and placebo. And the results are very convincing. You can see in the middle the aldosterone group. The middle bar was the most effective. On the left, the green bar is placebo. And then we have spironolactone, doxazosin, and bisoprolol. Spironolactone was the most effective of all the 3 medications used. And remember, those patients were hypertensive patients. They were not divided to groups according to levels of aldosterone. So if they would be divided, the result would be much more impressive. This is a mean value of a group. Some of them had higher, some of them had lower aldosterone levels. Again, another study published by a good friend of mine showing the association between potassium levels and decrease in systolic and diastolic blood pressure when aldosterone antagonists were given. And we can see, for instance, here, that the baseline potassium, when it's below 4.5, makes a big difference in response to aldosterone blockade. This is a general guide showing renin levels and the correlation with response to different medications. The green one is aldosterone blockade. So you can see here, this is aldosterone blockade. In low renin patients, the effect is maximal. Most of the low renin patients have high aldosterone levels, which reduces renin activity. And doxazosine alpha blockers are in blue. They do not make much difference, and normal levels of renin are associated with relatively good response. In the yellow are beta blockers, which are more effective when renin is high. So these, we do not always have results of renin levels, but if we do, it's a great guide for choosing the optimal and most effective medication for treatment. We can skip this one. Also, we had a lot of discussion, beta blockers. They were step 2 in 1977, very important for many years, excluded from the recommendations by the British and then other societies, and returned as before to the first and second line of treatment of hypertension. Now, we have different response according to age groups. So we can see that in elderly hypertensives, beta blockers are of minimal effect. However, diuretics are more than doubled in effect of blood pressure reduction. So in the elderly, diuretics are preferred. Beta blockers, we use them only if there is a concomitant disease like heart disease, ischemic heart disease, etc., etc. So this is also a good hint what to give in an elderly patient. Start with a diuretic. Now, effect of age. On the left, the 4 bars are younger people, less than 54. On the right, more than 54. And just note, the 2 lowest columns on the left are calcium channel blocker and hydrochlorothiazide diuretic. They are relatively not effective in the young. However, they become extremely effective in the old. So again, calcium channel blockers and diuretics are of best choice for elderly patients. Here we can see meta-analysis of clinical trials in elderly hypertensive patients according to the first-line treatment strategy. And it is so clear to see that the diuretics are significantly better than beta blockers in coronary heart disease and in most of the conditions on this slide. Gender. This is percent of patients developing hyponatremia. So the best medication for elderly patients are diuretics and calcium channel blockers. Let's look at the diuretics. They cause hyponatremia. If you look on the left, in young patients, no hyponatremia, almost zero. As they become older, huge increase in hyponatremia, and the black is females. Somehow females are very sensitive, men are less sensitive. But we can see that hyponatremia develops in about 60% of elderly patients developing hyponatremia. So first of all, diuretic is a treatment of choice in the elderly, most effective. However, we need a routine. I usually, when I start in an elderly patient, when I start a diuretic, I ask him within 1 month to send me his electrolyte levels, plasma electrolyte levels, to see the sodium. And there are many cases in the literature that an elderly patient especially a woman, received a diuretic, went home, and after 3 months, the physician called her, and he found that she was in an elderly house, limited, unresponsive, etc., etc. The diagnosis was dementia, but the sodium level when tested was very, very low. So hyponatremia is a must for evaluation in every patient, elderly, especially elderly patient, that we give them diuretics. Very effective, but has to be supervised. BMI, we had a beautiful lecture by Vasilios about obese patients, and obese subjects are volume dependent and therefore respond better to diuretics. They are hypervolemic and should be treated. And here is a comparison of combination of benazepril, an ACE inhibitor, and hydrochlorothiazide versus benazepril and amlodipine. And those are cardiovascular events. So in normal patients, there is high cardiovascular event rate. If they are treated with hydrochlorothiazide plus ACE inhibitor, there is significant decrease in obese patients in the events, while in non-obese patients, there is a decrease, but it is very, very slight. Hypertension in normal weight and obese patients might be mediated by different mechanisms. Thiazide-based treatment gives similar cardiovascular protection as amlodipine in obese patients. Now, what is important in obese subjects with high salt diet, there is a salt-sensitive hypertension, and those are the excellent patients for lowering dietary sodium, like the projects Bojan and Anna are doing for the last years in Croatia. It is very, very important, and it should be considered. Obese subjects have elevated aldosterone levels and therefore respond better to aldosterone antagonists. A list of concomitant disease that all of you know. Diabetes mellitus, we prefer ACE or ARB or CCBs. Ischemic heart disease, beta blockers. Congestive heart failure, ACE and ARB, and beta blockers, of course. Bronchial asthma, no beta blockers. Heart rate, sinus tachycardia, beta blockers preferred, no dihydropyridine calcium blockers. Sinus bradycardia, no beta blockers. Rapid atrial fibrillation, beta blockers, or non-dihydropyridine calcium blockers. Now, the must laboratory evaluation is kidney function, BUN, creatinine, and of course microalbuminuria in the bottom, fasting glucose, sodium, potassium, lipid profile, uric acid, calcium. Those are the most important, and those will help us to decide which medication we are going to choose. For hyperglycemia and elevated HbA1c, we prefer ACE or ARB and CCBs. Beta blockers and thiazides are not recommended for obvious reasons. For hyponatremia, don't use thiazide. If you have to use a diuretic, furosemide is safer. Hyperkalemia, beware of ACE, ARB, and aldosterone. Rule out secondary causes of hypertension and use potassium-sparing diuretics. So treatment with spironolactone is more effective when serum potassium levels are below 4.5. And is more effective the lower potassium level. If you have somebody that has potassium level below 4 or around 3.5, it's a screaming indication for aldosterone antagonist. The HDL cholesterol, try to avoid beta blockers unless there is compelling indication, if there is heart disease in the background. Hyperuricemia, avoid diuretics. Hypercalcemia, avoid thiazides. Use furosemides if diuretic is required. Furosemide is not an antihypertensive medication, but sometimes we use it for volume retention. Of course, microalbuminuria prefer ACE and ARB, and here a small comment. We know from many studies that we do not use ACE plus ARB. Why? No additive antihypertensive effect. However, ACE plus ARB can be beneficial for other reasons, especially the kidney. I have many patients with albuminuria, some of them massive, in which I treat with ACE plus ARB despite the recommendation, and there is a major decrease in albumin excretion. So probably there should be some kind of beneficial effect, and those two groups, ACE and ARBs, can be used together despite that there is no additive effect on blood pressure. Okay, when a given antihypertensive agent fails, what do? We have two choices. Either wait and see, which is usually not effective, or to switch to another agent. Maybe our choice was wrong, or maybe the patient is not taking our medication, in which case switching to another medication will not help because probably will not take the other one too. Increase the dose, depend what is the dose that we gave in the beginning. If it's maximal, we will increase side effect, we will do not receive additional antihypertensive effect. Or continue with another agent. Okay, we know all that, blood pressure and side effects. And I think this is the most important things. And I believe that we have to distribute this information to all our physicians and students. And one conclusion from my presentation is that aldosterone antagonists are not used enough. They have tissue protective effects, they can prolong life, they can prevent complications, they can improve. Although, you know, in many family physicians, they say, oh, the creatinine is 1.3, I'm afraid to give aldosterone. I gave it 1.4 and 1.5 also, but I gave half a tablet of 25 3 times a week in the beginning. After 1 month, I look at the creatinine levels. Usually it increases a little bit from 1.3 to 1.4. And then I wait another month. When it's stable, usually it improves. I increase the dose, and we can do it gradually, also looking at the potassium levels, which also will increase. So the main thing is we do not use enough aldosterone blocking agents. And we have to think of it. In many patients, it will bring a big benefit. Thank you.